Good evening, everyone. I'm Chris Stover, the Executive Director of the Canadian Centre for Ethics in Public Affairs. CCEPA is a joint venture of the Atlantic School of Theology and St. Mary's University, with a mandate to create and stimulate public conversations about how we live and things that matter. Tonight, we've partnered with the Dalhousie Health Law Institute, with the additional support of the Nova Scotia Nurses Union, to talk about vaccination, as well as the Canadian Centre for Vaccinology. The recent measles outbreak has renewed an always simmering debate surrounding vaccine, revealing a public tension that begs for reasoned conversation. Not the regular polarized debate, but a community engagement on the importance of considering collective good, weighed with a right to choose, and the consequences and implications of those notions. We've assembled a knowledgeable group of individuals to help us explore the various considerations in achieving that balance of collective and individual rights when we think about the choices we make about the health of our communities. Our moderator for tonight's discussion is Kevin Kindred, a Halifax lawyer and part-time faculty member at the Schulich School of Law at Dalhousie, where he teaches employment law and privacy law. Kevin is an activist and on issues of equality, secularism, anti-poverty, and civil liberties, and has also served on CCEPA's programming committee for many years. Before I turn things over to Kevin, I'll call your attention to the slips of paper that you probably saw on your chairs when you came in. It advertises a couple of events that CCEPA will be doing in the next couple of months, but there's also an evaluation form that you'll see there. And it's really important that you take the time to fill that out. It helps us, that feedback helps us create future programs that serve the public in the best way we can. Thanks.
Great. Thank you. Thank you, Chris. And welcome, everyone. Welcome to Paul O'Regan Hall, this great facility that we have at the Public Library downtown. I'm so happy to have seen so many great events like this right in the core of the city. So my job as moderator, I have been an activist in Halifax on a number of things for quite a while. The extent of my activism on issues of vaccines is reading things that annoy me and posting them on Facebook. And if that makes me an expert on vaccines, to the same way that, watching cat videos makes me a veterinarian. So luckily, we're not going to rely at all on my expertise on this topic, but CCEPA has brought together a panel of experts, and, I think it's worth saying these are world-recognized experts on the issue of vaccines. Probably the best panel that we could assemble in Nova Scotia. This would be my dream panel of people to talk about this issue. So CCEPA has really given some effort to make sure that you have the opportunity to ask people who know the most about this topic and who have thought the most about this topic for their perspectives on it. The ground rules for discussion. So we've set two themes that we think kind of engage in this issue, and I'm going to ask the panelists to comment on each separately. So in the first half of the discussion, we'll be addressing the theme of mandatory vaccinations for children and the general population. And then the second discussion will focus more specifically on mandatory vaccination in the healthcare sector for healthcare workers. But we have tried to adopt a format, and at CCEPA we think a lot about our formats and how they maximize audience engagement. So we are going to ask the panelists to make very short statements, setting out basically their thoughts on the topics, but only in a very few minutes, and then engage almost immediately in audience questions. So when you have a question, I'd ask you to line up at one of the two microphones here, and I'll be willing to take your question and moderate it. We're also going to take questions from our live streamed online audience, which I'll be getting on little slips of paper. So if you see someone running up to me, that's what that's about. When it comes to questions, I just want you to keep in mind a few things. First of all, we do want questions for the panelists. Sometimes at these events, questions become more long, rambling statements about the topic. And while we are interested in your views, we really would like you to take the opportunity to ask a question that the panelists can answer. I also want to keep in mind that this question, the panel is focusing on the intersection of health science and public policy. And when it comes to the question of vaccinations, I think all of our panelists accept, within an acceptable range of disagreement, the science behind vaccinations. So this is not really a debate about, it's not a science debate about vaccinations. We're working within a well-defined and accepted scientific mainstream view of vaccinations, but there are a lot of questions about what to do given that accepted mainstream science when it comes to people who object to being vaccinated or forcing vaccinations on the population. So that's really what we're going to focus on, and I'll ask if you have questions about the science. Our panelists are able to answer those and quite expert in them. But the debate is really on the civil liberties and privacy implications of mandatory vaccinations. So, without further ado then, I'm going to introduce you to your panel. And starting on my immediate left, we have Elaine Gibson. Elaine is an associate professor of law at the Schulich School of Law and a member of Dalhousie's Health Law Institute, one of the sponsors here tonight. Her research topics include healthcare policy, health law and policy, medical malpractice, negligence, and public health law. And she is the co-principal investigator of facilitating access to health data for research and planning in light of laws and ethical norms. That's a project of the Canadian Institute of Health Research. So welcome, Elaine. Next to Elaine, Dr. Scott Halperin has served as head of infectious diseases at the IWK Health Centre in Halifax, Nova Scotia, and is director of the Canadian Centerfor Vaccinology, a joint collaboration of the IWK Health Centre, Capital Health, and Dalhousie University. He's one of the world's leading authorities on the development of vaccines, and his research focuses on the diagnosis, treatment, and prevention of pertussis, or whooping cough, and other vaccine-preventable diseases such as influenza. Welcome, Dr. Halperin. Next, we have Janet Hazelton. Janet is the president of the Nova Scotia Nurses Union and has been since October 2002. She has a long history as a union activist and advocate for healthcare and nursing issues. And on behalf of the Nova Scotia Nurses Union, Janet adamantly supports the right to public and accessible healthcare for all Nova Scotians, not just those living in densely populated areas of the province. Welcome, Janet. And finally, last but not least, on the end of the table, Dr. Robert Strang. Dr. Robert Strang is the Chief Public Health Officer and Acting Chief Medical Officer of Health for Nova Scotia. He is the Associate Medical Officer of Health, served as the Associate Medical Officer of Health in British Columbia from 1997 to 99, and in 1999 moved to Halifax to become Medical Officer of Health for Capital District Health Authority. In January 2007, he became Acting Deputy Chief Medical Officer for Health for the province, and Dr. Strang was appointed Nova Scotia's first Chief Public Health Officer in August 2007. So welcome to our panel. Okay, so without further ado, the first question, the first theme, and we're going to have the panelists make general statements, short statements on this theme, and then invite questions from the audience, and I'll throw in some as moderator as well to kind of play out or tease out some of the issues. So the first theme, the issue of childhood and general population vaccinations. We've encountered stories in the news, including Canadian stories, about the resurgence of childhood diseases many of us no longer think of as a threat, and it seems to relate to a lack of childhood vaccinations. Many have suggested state policy responses that would impose, in one way or another, the mandatory vaccination of children or others in the general population, or the tracking of vaccinations. Those proposals have implications for our privacy and for civil liberties. So I'm going to ask the panelists what we know about this trend, and how do we find policies on that issue that strike the right balance between health policy, protection of health, and the civil liberties and privacy of the individuals involved. So I'd first pose that question to Dr. Strang.
Thank you, Kevin, and good evening, everybody. Thanks for the opportunity. So it's a basic public health principle that, virtually everything we do in public health, there's a tension between what's the collective good, what's best for the collective good, and what is the right of individuals to make choices. And we always work with that tension. And a public health principle is to use the least intrusive interventions necessary to get the outcome you're looking for, and to make the least imposition on infringing on people's individual rights while you try to protect the health of the collective. On the issue of mandatory immunizations, I think there's lots of things we should be doing in Canada to understand what our immunization rates actually are. We have lots of gaps in truly understanding what percentage of Canadians, whether they're infants, young children, adults, get immunized at the appropriate time for a range of vaccines. And especially being able to take that information and drill it down. And so we have general population rates, but ideally we'd be able to look at what's the immunization rate in North End Halifax, what's the immunization rate in different subsets of the population, and then be able to say there's areas where we have a lot more work to do, where there's much lower immunization rates than elsewhere. So that's just one piece. So I think there's a lot of things we need to be doing that are less intrusive than mandatory vaccinations. And my position would be that we should be spending our time and attention on improving in those areas. And once we were maximally functioning in those areas, it may be then we have to consider mandatory as the next step. But if we follow the public health principle of least intrusive, we have a lot of things that we need to be doing better in that are less intrusive than pure mandatory policies at this point in time.
Okay, thank you. And on the same question, I'd like to ask Dr. Halperin.
Thank you. I think I go from a position that vaccines are a public good, and vaccination, for example, was identified as the #1 public health intervention in the 20th century and continuing on to the 21st century. Vaccines have been very effective. They've protected individuals against many of the most deadly diseases, including diphtheria, tetanus, pertussis, measles, various forms of meningitis. Vaccines have a capability of protecting both the individual, but also the people that are around the individual. And that's the concept of community immunity, so community protection. If enough people are immunized, then transmission of the infection is interfered with, and it's interrupted, and then the pathogen no longer can circulate in the community. And this has the added benefit of protecting people who don't respond to the vaccines because they may be immunocompromised or aren't able to be immunized for some other reason. So immunization, to me, is part of the social contract that we have of living together as a society. In order to get these benefits of community protection, one really needs to have high levels of immunization uptake in the community, which is what Dr. Strang was saying, and we need to know what those levels are. If the levels drop in the community, then these infections come back, because most infections, we're not eliminating the infection, we're just stopping it from transmitting itself through the population and causing disease. So in cases where population immunity is dropped down, the organism is reintroduced into the community and you have outbreaks. If our goal of high levels of protection can be achieved voluntarily, then there's really no need for mandatory immunization. However, if we're not successful about achieving them voluntarily, then mandates are a reasonable societal intervention in order to achieve the goal, which is protection against these deadly diseases.
Okay, thank you very much. And again, on the same theme, I'd like to ask Elaine for your response.
So we may prove to be a boring panel in certain respects, in that so far we have a fair degree of agreement, I think, among us. Dr. Strang, I think, has received legal training. He may not admit it, but in his speaking about requiring the minimally intrusive, least coercive method, that is absolutely what is required according to the Canadian Charter of Rights and Freedoms and human rights legislation in Canada. And there are many legal tools available short of actual coercion to accomplish the very important goals of vaccination of children. What are some of these tools? Well, there are a whole bunch of tools in the toolkit that have to do with positive initiatives, carrots, that we may not have tried yet. For instance, there are financial incentives to healthcare providers. So many healthcare providers do not, between the study done between the ages of 1 and 2, parents of children between age 1 and 2, in the 60 or 70%, the physician does not discuss with the parent the need for immunization. So financial incentives to healthcare providers have been tried successfully in the United Kingdom. Financial incentives to parents have been tried successfully in Australia, where the parent receives a bonus for having their child vaccinated and a very substantial child care contribution to pay for child care of children under school age. There's also just education, use of the spending power, making vaccines available in all sorts of settings so that it's much more easy to actually gain compliance. And in fact, in Canada, in one of the studies at least, only 1% of parents had not had their child vaccinated in at least one vaccination. So this shows that the far fringe who is refusing all vaccination is actually a very far fringe, and that compliance methods can be very effective. Now, you can then get on to the more punitive measures in law, such as the use of the tax system in a disincentive way through, for instance, non-receipt of child tax benefit. The more dramatic one that's being flouted at times for being considered is denial of school entry or continuation in school. There's also fines and imprisonment, of course, in law, but these are the more dramatic, and it's my position that we need, and definitely in law, we need to try and demonstrate whether those other less draconian methods are successful before we move to anything like compulsory vaccination.
Okay, thank you, Elaine. And finally, Janet, I know that your focus is really on theme 2, which is mandatory vaccination for healthcare workers, but in light of what the other panelists have said, do you have any comments at this point?
Obviously, the Nova Scotia Nurses Union does support vaccinations. I'm assuming most of you have seen us on TV talking about and encouraging healthcare workers and others to get their vaccination. And to Elaine's comment, as a little joke, I am a union leader, so if we could get some bonus money for nurses to get vaccinated, I'll think about it. So, I mean, we feel very strongly, the Nurses Union. I'm here to discuss what the nurses I represent, and I represent 7,000 nurses in this province, and they work in all sectors, home care, all of the VON nurses, all of the nurses in acute care, or most of the nurses in acute care, and at the IWK. So we asked our nurses last year what they felt about having mandatory vaccinations. So would they agree if that was proposed to us in contract negotiations? Would they be happy with the Nurses Union if we agreed to that? And 70% of our nurses said absolutely not. They believe strongly that they have the right to make that choice, and it ought not to be a condition of their employment. Nurses and physicians every day speak with patients about what they should or shouldn't take and what they should and shouldn't do for their bodies. So we talk to patients about the value of chemotherapy or the value of taking a blood pressure medication, why they should take it, or why they should go for a walk or be on a diet, or all those kinds of things. And we give our patients all the information they are required to have to make the decision. But ultimately, it's their decision to make. They get to decide whether they will or whether they won't do what is recommended by their physicians and or their nurses or other healthcare providers. We believe you cannot take that decision-making ability from them when it comes to their own health care. Most nurses and physicians, I believe, will take the vaccination if it's offered where they are or when they're working. I believe they'll take it, but some will not. Some will not take it for the same reason some people in this room won't take it. There's some of you in this room that, for whatever reason, is opposed to vaccinations. And no matter how much education you get, you're still going to be opposed to vaccination. Now think if that was a condition of your employment. That's where the nurses union is saying it ought not to be a condition of anyone's employment. Other means, hand washing, masks, can be used if nurses and physicians choose not to have a vaccination. So this is pretty much the feeling of nurse unions across the country. And for that matter, most healthcare unions believe that's where we stand on this issue. We don't take a position, obviously, that children should be mandatorily vaccinated when we say we shouldn't be. That would be a tad hypocritical. So I think that's it.
Okay, thank you. So, and a lot of those comments sort of anticipate what theme 2 is going to be on, focusing on mandatory vaccination of healthcare workers. But first, getting back to the issue of childhood or general population mandatory vaccinations. So we're ready now to open up for questions from the audience, and I'd encourage you to come forward to either of the 2 microphones that are here. If you have a mobility issue that prevents you from coming forward, please let us know, and we'll get a microphone to you. But if you can raise your hand, we'll take care of that. And we also have the folks who are live streaming. Keep in mind that you can put questions in as well, and I'll accept them. So I'm going to kick off with one question that picks up from something that Dr. Strang said, really, because each of you have spoken about the collective good versus individual liberty and the need for voluntary measures first. But there is some evidence that voluntary measures will never achieve complete vaccination. There was an article in the Globe and Mail today or recently saying that despite parents who objected to vaccinating their children, who learned about the measles outbreak in Quebec, that had no impact on their decision to vaccinate children. So there's going to be a point at which education and all voluntary methods don't achieve maximum possible vaccination. So to ask it maybe in a bit of a pointed way, shouldn't the concern for public health at that point override the individual objections if we're trying to balance the collective good and individual liberty? Anyone want to jump in?
Well, I think it's, in short, yes. How far you go for that is the question, really. But yeah, I think part of we need to change some of the conversation to be more focused on the collective good, because many people's decisions are, and I've talked with many people who choose to delay or not get vaccinated, and it's really focused on themselves or their children. So I think we need to do a lot more to say, let's have a discussion about what the impact about individual choice is on others, and frame the discussion more about what's actually necessary. There's things we have to do every day if we're going to have a functional, cohesive society that we all have to have give and take. And as Scott has outlined, this is a collective social good that we have achieved huge benefits in the last century more, that we have to pay much more attention to what were the potential implications of individually focused decisions and what those implications are. So I think there's a lot more dialogue on that. And I also think we then have to say, if people choose not to get immunized, make it much clearer what the potential consequences may be. So make it very clear that if we have an outbreak of pertussis in Halifax, if we have children that are not fully immunized against pertussis, they will be told to be, and we can enforce this with the Health Protection Act, be required to be at home and not at school for the length of that outbreak. We don't have those kind of dialogues with parents and families. And so we need to say, if you choose certain actions, there will be certain consequences, and make that very clear, and be open and honest about those dialogues.
Okay. And Elaine, I think on the same point.
So I want to reinforce something that Dr. Halperin was talking about, and that is he was referring to it as, I think, collective immunity, herd immunity, it's also called. This is of fundamental importance. When each person gets their child vaccinated, they are participating in a collective effort for Canadian society. They are benefiting their child to some degree, but they are benefiting society to a higher degree, and this is an extremely important aspect of public health generally and of vaccination specifically. Parents who decide not to get their child vaccinated when the science is very clear, those parents are acting, I'm going to say it directly, even though I was talking all about, in my first intervention, I was talking all about the need for a positive response. Those parents are acting in a profoundly selfish manner, and it's very problematic, and in my view, it's against Canadian collective values to not have one's child immunized against the basic diseases that, where the science is very clear that those vaccinations carry low risk and high benefit. And we need then a measured response. So I talked about the least interventionist response. If we have a serious problem developing, then we need to ramp up those responses, and ultimately, I would come down in favor of the most interventionist response where necessary. I don't think we're nearly at that point, and as I said before, we need to explore other methods of education and of positive incentives before we get to the negative ones, but I'm all in favor of the negative ones where necessary, if established as necessary.
Okay. And Scott, did you want to speak to that as well?
No.
Okay. In that case, I'll go to the first question from the audience, and I'm going to alternate between the microphones, so I'll go here first.
I really am opposed to vaccine out of my own experience. My background is radiology, and by the way, one of my daughters got pertussis after getting her vaccine, and was from October to May. She had whooping cough. My main question, as a person in the healthcare field, and all of you are, you know how little research has been done into research on so many things. The head of internal medicine had said some time ago, there's nothing that she uses in her practice now that she learned 35 years ago. And questions on the research of all of these vaccines, very different than early 70s when my daughter was vaccinated. The manufacturers have been sued in various ways. They now are not legally responsible for consequences. They were initially. Again, this is in the States. So therefore, what I question is, why are we not saying we should have preventative health care? It's never been a priority in hospital. Why is that not being advocated? Family physicians, there's not a lot of training, and I've recently checked with medical students now on helping people make informed choices because they don't know. And therefore, I say, how when these big pharmaceutical companies are not accountable, when the research and the information being given to all of you is through pharmaceutical companies and all of that, how can you, in good faith, say things like, no matter how much education you get, you won't change? Because, in fact, you don't know. There hasn't been the research. There hasn't been research in so many things.
Okay. So I'd like to take from that question, there are two things that I might take from that to direct to the panel. One, a question about the efficacy of the research and the suggestion that the research is incomplete or that we just don't know. I think that question is probably best directed to Scott first. And then secondly, I also take a question about the impact of teaching preventative medicine and how that might fit into the various policies that respond to public health crises. So Scott first, if you...
Sure. I mean, vaccines are one of the most regulated products on the market. and they all go through very rigorous research before they get to the market. Research is done in preclinical work, which is done in vitro in test tubes. It's then done in animals, and ultimately it gets into clinical trials. And the clinical trials go through multiple phases, going to make sure that the vaccines are both safe and effective.
You're not answering the question.
Sorry.
Research has been done on all of the vaccines, the effect, nothing.
So all the vaccine research, so on each vaccine is done, and each vaccine, when it's put onto the market, has to be tested with any other vaccines that are being given at the same time. So indeed, clinical trials are done when a new vaccine is done. If I want to give 2 vaccines on the same day, there have to be clinical trials to show that those vaccines are safe when given together. So there's clearly research that's being done, and vaccines are obviously made by manufacturers. Somebody has to manufacture the vaccines. Those vaccine manufacturers are accountable for their products. They're liable for their products. In the United States, they have a system where a proportion of every dollar that's spent on a vaccine that the manufacturer gets is put into a large pot of money, which then there is a compensation system for anyone who might be harmed by a vaccine, because vaccines, like any other product, any other drug, have side effects. They're not 100% so people can have side effects, and occasionally those side effects can be severe. It's rare, but it occurs, and the U.S. has a compensation system for that. Quebec has a compensation system as well.
Sorry, I'd really like the panelists to be able to speak and not have this be a back and forth between specific audience members and panelists. Thank you.
So manufacturers are responsible for their products, and there's a regulatory system in Canada that's responsible for making sure that the products are safe and effective before they get to the market. And there are surveillance systems that take place that occur in Canada that monitor for adverse events, so that we know the frequency and related to each vaccine. So it's a very safe system, and vaccines are monitored throughout their lifespan. So even after a vaccine's been on the market for a while, there continues to be research done on the vaccines to demonstrate their safety and ensure the public that they are safe.
Okay. Anyone else on that first part of the question about the research before engaging the second part of the question about preventative health?
I just would point out that Dr. Halperin is extremely well situated to be commenting on this, and also to be free of industry influence in what he's saying, in that the center is publicly funded and, to my knowledge, not funded by any manufacturers.
Our research center does not get funds for running the center, but we certainly do clinical trials that are sponsored by industry. So we do both industry-sponsored studies and non-industry-sponsored studies.
Okay. And on the question of the role of preventative health training in disease control management?
Well, I mean, I don't disagree that we need a stronger focus of prevention in all the aspects of prevention. However, as Scott had said in his opening remarks, one of the most important preventive measures in the last century has been the implementation of a number of childhood vaccinations. So we need to continue to work at vaccines and working to ensure we have the highest possible uptake of vaccines as part of that increased focus on preventive health care.
Vaccines prevent infectious diseases. Infections are transmitted from person to person, and vaccines are the preventative measure for infectious diseases. If you have a disease like measles, if you have not been immunized or have not had measles, and you are in a room with somebody with measles, you have over a 95% chance that you're going to get measles. You can wash your hands until the cows come home. You're going to get measles. It's the most infectious virus that we know of. So the only prevention for measles is either not coming in contact with human beings or vaccine.
Okay. I'd like now to go to this mic, and I think, sir, you were first at this microphone.
Okay, just a quick commentary and I suppose question that was following from the ma'ams over there that asked it previous. My summarization of my understanding of what you folks just said was that there is not 100% safe. Vaccines aren't 100% proven to be safe, and therefore we're not sure. There's a bunch of allegations if they're linked to autism and other abnormalities that kind of surface at that stage of the child's life. I think that's, Janet, you said you're not sure why people still say that they don't want vaccinations. I think that's probably the primary reason. And Elaine, you mentioned that you think it's a public disservice if people don't get it. But with information like that, I think a lot of mothers and family members have the dilemma: do I risk autism or other abnormalities that could be linked, or do I, go for the vaccination? But my question is more specifically linked to the privatization of vaccinations and other drugs on the market today. Why are they not made public versus private? What's the legalities involved in that? And doesn't allowing the privatization of vaccines and other drugs create the very dilemma that we're facing today, which is the choice not to have these done? But also, a lot of families in other countries, and even our own, are dying needlessly if they don't have access to these vaccinations and drugs. So what's Canada's, as a world player, what are we doing to address that? Because if there's measles and other vaccine solutions throughout the world, why aren't we sharing that with the world?
Okay. So again, two things that I'm going to take out of that question, because I don't want to let go unaddressed the question about risk of vaccines, and particularly the reference to autism or other abnormalities. And Scott, you may again be in a position to comment on that. But the question is about the privatization of vaccines and Canada's role in ensuring that vaccines are distributed to places where they're needed. So I don't know, Scott, if you want to intervene on that first point.
Sure, I can talk about that. I mean, if the current system that we have in Canada and in industrialized world is that vaccines are manufactured by private companies. That's not always been the case. Governments were involved with vaccination, but they ultimately decided that they needed entities that were expert in that field and that focused just on that. So in Canada, when the polio vaccine was first discovered and first came out, it was by Connaught Laboratories, and Connaught Laboratories was part of a government process. There was Armand Frappier in Quebec. Ultimately, the governments got out of the vaccine business because they couldn't do it efficiently. That does lead to problems, and the biggest problems are the discrepancy and the divergence between the industrialized world and the developing world, where not all vaccines are available everywhere. Fortunately, there's tiered pricing that occurs throughout the world, so vaccines like against diphtheria and whooping cough and measles are all available at pennies a dose in the developing world, and all children have access to those vaccines. Not that the uptake is 100%, like in everywhere else, but they have access. The bigger problem is more expensive vaccines that are more recently, like some of the meningitis vaccines. And there's a lot of effort to bridge those gaps. And the Gates Foundation has been a leader in trying to get the technology to the developing world. And I think one of the successes of that has been the recent implementation of a meningococcal A conjugate vaccine called Menafrovac, which is a vaccine that is targeted against a type of meningitis that's particularly in what's called the meningitis belt of Africa. And that is being done through a collaborative partnership between the developed and the developing world, where the vaccine is manufactured in India, it's manufactured at a cheap dose, and it was implemented successfully in some of the poorest countries across Africa. So there are solutions, and they need to be done for a lot of the other vaccines, the HPV vaccine, which is against cervical cancer. Cervical cancer is a much bigger problem in the developing world, and getting that vaccine, which is very expensive to the developing world, has to be a priority. So I can't agree with you more. I mean, it's not just because it's private manufacturers, it's the whole system, but there are ways around that too.
Okay, any other panelists on that question? Okay, if not, then I'm going to go to sort of our third line, which is questions coming in from the online viewers. Oh, sorry.
I thought you were talking about the global piece. I do need to respond around the safety piece, just quickly.
Please do.
Nothing in life is 100% safe. Just walking here today in the icy streets, you had some small risk of falling and getting a subdural hematoma and dying. Nothing in life is 100% safe. But we do know there is tons and tons of very credible research that the very small risks of very discrete, well-known complications from vaccines is far, far outweighed. So that risk for any person is far, far outweighed by the benefits of preventing well-known deaths from measles, from meningitis, etc., etc. There is lots of people claiming that there are links to autism, multiple sclerosis, but when you actually take a look at what the evidence says and not what anecdote and celebrities say, those stories do not play out. There is no evidence that autism is caused by vaccines. And I'll tell you, some personally, I have a son with autism, and I get very offended by all this world out there that wants to link autism with vaccines. It distracts the autism world from looking at real causes and cures. So we have to make sure that our discussion around vaccination is based on what the evidence tells us. And is evidence perfect? No. But we have to make decisions around what the current evidence is in front of us. And 10 years from now, if we have different evidence, we may make different decisions. So let's make sure that we have an evidence-based, not an anecdotal, celebrity-based discussion around vaccines, please.
Okay, I'm going to turn to the online question, and feel free to keep lining up the other two microphones. So, in terms of childhood vaccinations, what kind of precedents are there in Canada for methods that have been taken to enforce vaccination rates in children, and what role should schools and school boards play, if any? So I would just note, reviewing some of the research, including some that the panelists have been involved in, that the data that I was most able to review doesn't tell a great story about Canadian provinces living up to the standard level of childhood vaccinations, and that very few of the provinces seem to be vaccinated at the level that the federal government has set as a standard. You're much better able to comment on it than I have. But are there strategies elsewhere in Canada for measures that have been taken to enforce, to improve those rates of vaccinations, and should school boards play a role? I'll go to Elaine first.
So 3 provinces have legislated requirements about public school entry. Those are Ontario, Manitoba, and New Brunswick. And they have a requirement either that a child produce evidence upon entry to school, or once they are enrolled at some point in the first year, that the child has their vaccinations up to date. Ontario also has a requirement for licensed daycares to ensure that a child has received the proper vaccinations to be in that daycare. And those are the provinces which have legislated in that way. Every province has public health legislation that would kick in at time of need, where a child could be banned from school, for instance, in case of an outbreak. So those are the more strong measures in every province, but short of an actual outbreak that leads to necessary measures kicking in, it's only the 3 provinces that have acted in the way that I'm referring to in terms of school entry. And school entry is the approach that's been taken in those 3 provinces as opposed to just a straight mandating of vaccines for children, because it's kind of the easier method, I think, because you've got an automatic mechanism kicking in when the child is commencing school and when they re-enter each grade subsequently, that you can do the screening at that point, as opposed to some other kind of ensuring that their vaccination records are up to date. It does enable, though, the possibility of homeschooling, for instance, for children who've not received vaccinations, and in some circumstances, private schools not having that vaccination, depending on the way that the legislation is drafted.
Okay. Any other panelists on strategies from elsewhere in Canada and the role of schools?
Even in provinces, the provinces that don't have school entry legislation, vaccination status is checked at the time of school entry, and if the child's immunizations are not up to date, it's suggested to the parents that they get their child immunized. And having done that, there's not a lot of evidence to show that there are differences across Canada. There are so many holes in terms of exemptions in the provinces that have legislation. Religious exemptions, philosophical exemptions, just don't want it exemptions, that the rates aren't substantially higher in Ontario, New Brunswick, where the legislation is in place. So we still need to do better in terms of getting the kids immunized.
Okay. Anyone else? Dr. Strang, I don't know if this seems like it's up your alley.
Well, I don't think Scott's absolutely right. There's no part of the country which is so far ahead by doing something different that we all need to look to that and go, wow, there's something we need to be adopting. We're all wrestling with similar issues in an evolving world around growing numbers of vaccines and growing questions around vaccines. How do we continue to make sure we have good vaccine coverage? And none of us have found a magic bullet. Not that there is one out there, really, but I think there's certainly lots of national dialogue about how we deal with this, and I think that's one of the things we need to pay more attention to, is that linking with researchers and perhaps trying some different things, measuring and monitoring and sharing that information across the country, and just trying different things to see what could actually make a difference.
Okay, thank you. I will need to move to our second theme, but there's one more person in line who's been in line for a while, so I'll allow you to ask your question now.
Thank you. I'm going to read a couple of very short paragraphs.
I hope they're very short.
Very short. Okay. From a recent article in the Globe and Mail. A new study released this week by the C.D. Howe Institute found that some provinces are achieving much higher vaccination rates than others. No province comprehensively tracks immunization status from birth, something that would help public health officials to identify pockets of vulnerability during outbreaks. Only Newfoundland and Labrador top 90% for all shots, including measles, mumps, chickenpox, diphtheria, tetanus, and whooping cough. And my understanding is 95% is about the required level for herd immunity. New Brunswick had 69% coverage for measles, mumps, and rubella, just ahead of Nova Scotia at 66%, the lowest rates among provinces. And I would ask you to comment on those numbers.
Okay.
So we were talking about this beforehand, and another measure that I considered discussing when I was talking about legal measures that could kick in, and it's a quasi-legal measure, I suppose, but definitely collaboration among the provinces and the federal government is needed, and we need a comprehensive system of tracking. So I'm not going to talk about Nova Scotia's lower compliance rate according to the one study. What is happening is that we have poor information about compliance and about who's getting vaccinated. We do not have a national registry for vaccination, such as Australia has. And Australia is a federation also, and they've gotten past the desire of the independent units within it to not share the information. They have a national vaccination registry. We desperately need that so that we know the situation in Canada, such that we can know when herd immunity might be failing and when we need to take more strong measures.
I would agree with what Elaine said. I think one of our greatest lacks in Canada is a registry where we would know what individuals have gotten vaccinated. We've done a number of studies here in Nova Scotia that indicates that if you really want to know whether somebody's been immunized and what vaccine they've gotten, you have to go to at least multiple sources. When we did the study, it was 3 sources. You had to go to the family physician's records, you had to go to public health's records, and sometimes the parent's own vaccine card had information on it that weren't in the other 2 places. We've just complicated that more, which I think is a good thing, in that we now have pharmacies as another place we have to go to. So in order to get accurate information and really see what the level is, we have to go to 4 different sources. There's no reason in today, with the technology we have available, that we shouldn't have a good vaccine registry that has that information that's portable as Canadians are, so that if they don't move from Nova Scotia to PEI or even to Vancouver, and that their information tracks with them. We need to get that information available and have it not only available to the parents but to healthcare providers, so that when you go into the emergency room after an accident or wound, you know whether you need a tetanus vaccine or not. People are getting immunized, they don't know, and they're not getting immunized because they don't know. So I think that I'm always concerned about the vaccine coverage information because I'm so untrusting of the data that's available. And whether Nova Scotia is the lowest province, I don't know. Certainly what experience we have is that, as Rob said, we're not better, we're not worse, and the problem is across Canada.
So, Robert, is that number about poor data or something else, or a combination of both?
I think we have poor data because we haven't invested in the information technology systems to actually get good data. So I absolutely agree. It's a fundamental, and I said this at the outset, if one place where we said we need to pay a significant attention across this country is developing an electronic registry. I mean, how many of us have smartphones? I think there's apps out there which give you your immunization data. We're developing physician offices with electronic records, pharmacies with electronic records. That's great, but unless all that information on individuals can get fed into a system that then looks at aggregate coverage rates, and there's lots of ways to do it very simply that then you don't have to disclose anybody's personal information through that system, so that in my world I could look at that and I could say, what's my coverage rate? How many 2-year-olds are fully immunized by their 2nd birthday in Nova Scotia? And I could compare that to other provinces, and I could actually break that down and say, how does Amherst compare to Truro, and how does break it down by census tract? And I could go, those census tracts which are lower on the socioeconomic scale, how do they compare with other ones? That kind of work. I can't do that, but it shouldn't be that hard, but it seems to be a struggle. Frankly, it's about money. And we invest lots and lots of money in information systems in the healthcare, but it's, again, the lack of emphasis on investing on the preventive side.
Like so much public policy, I guess, the making decisions in the absence of data is a major part of the challenge. I'm going to move now to our second theme. So healthcare professionals are in a unique position when it comes to the spread of disease. Most of us can take some measures in our lives to remove ourselves from environments where disease is spread, but healthcare workers are in the opposite position. The job demands exposure to disease and service to patients. So when we have crises around communicable diseases like the flu, we often look to what measures healthcare workers are required to take. Not infrequently, there is a suggestion that if, in order to work in the healthcare system, you ought to be required to be vaccinated. So what do we think as a panel about the prospect of mandatory vaccinations for healthcare workers? Janet, you've been silent for the first half, but I know that this is the issue that you are most concerned about, and you did set out your position earlier on. But if you want to take a minute now and just reiterate the NSNU's position.
I think that we're talking about two different issues when we're talking about childhood vaccines and flu vaccines. Clearly, a flu vaccine that is taken every year by individuals. So I think they're two separate conversations for sure. And as I indicated before, we've done a lot of talking about this with our nurses across this country about whether or not they believe it ought to be mandatory. And clearly, they believe that it ought not to be. And it's not that nurses don't believe they should take the vaccine. It's that they should believe they shouldn't be made to take the vaccine. And like I indicated before, it's for all kinds of reasons, some of which that they believe that they can make their own healthcare decisions, just like they believe their patients can make their own healthcare decisions. Another issue is, so what next? And what's going to happen next? What is the next thing that I'm going to have to do in order to come to work? We're also quite concerned about how it gets monitored, how it gets tracked. In some provinces, those that didn't get their vaccines had to wear a sticker all day to indicate to everyone that they hadn't been vaccinated, like the scarlet letter. That created a lot of problems in the facilities that did that. Healthcare workers and nurses were very upset to be set apart from others. If you ask someone if they took the vaccine and they say they did, then they did. We're trusting these individuals to give medications, to look after patients, to chart on patients, so we have to trust them when they say that they took it. Apparently, if they didn't provide written proof, then they had to wear these stickers to indicate to everybody that they hadn't taken the flu vaccine.
So sorry, I want to make sure each panelist gets a chance on this point because we haven't heard that necessarily on healthcare workers. So, Janet's position has been set out quite clearly. I'd like to hear from the other panelists from that, maybe starting with Elaine.
Sure. I think that there are serious differences. I agree absolutely. One is that we're talking about adults who have health education when we're talking about healthcare workers and whether they should receive the vaccinations mandatorily. We're talking about, if you're talking about a hospital or nursing home setting, the effects of not being vaccinated automatically are inflicted on the sick and the vulnerable and people who are unable to escape their present situation. They're captive. On the other hand, the ante when it comes to flu vaccine is that the effectiveness is much lower than many of the childhood vaccinations that we're talking about when we're talking about an annual flu vaccine. And the studies on actual prevention are inconclusive so far as to whether they prevent the spread of influenza to the populations in the hospitals and nursing homes. So the balancing then depends actually on the level of intrusiveness of the type of intervention that is planned for the flu vaccination. And I'll stop there, but I'm sure we'll have more to say as we discuss it.
Okay. Robert, on that point?
So I'm not sure if I agree with Elaine on the lack of evidence. I think it's not complete, but there's certainly some pretty good evidence in the long-term care setting that immunized healthcare workers who get flu vaccine actually prevent the spread and save lives. I think the other nuance in the healthcare worker discussion that's different than the general public is that doctors and nurses and other healthcare providers are actually chosen to go in this profession, and they have a professional responsibility to provide safe, appropriate care to their patients and to take steps to minimize any harm. So I think there's an added professional responsibility lens that we need to apply to this of why a healthcare worker should be required to have a flu vaccination. that's different than the general public conversation.
Okay, and finally on that question is Scott.
Sure. I think my position is that influenza vaccination for healthcare providers is a benefit for both the health of the individual healthcare provider, but also their patients. I think the priority amongst healthcare providers should be to provide a safe environment for their patients, people who entrust themselves to their care. And we do have evidence that the influenza vaccines are safe and they are effective in preventing, again, transmission to the highest risk, which are in long-term care facilities. Multiple interventions have been tried to achieve higher rates of immunization amongst healthcare workers. And in general, there are a number of these strategies that are effective, and all of them increase the rates. But typically, we can't get those rates over about, at our best, 70%. Most years, it's around 50%, meaning that 50% of healthcare providers are not getting immunized, which I think is far too low. I look at it as, is there a right to be a healthcare provider? Do we have a right to say to people, if you want to be a healthcare provider, you have to take all reasonable steps to prevent transmitting infection to your patients? I think that is reasonable. We require masks in the operating room. If somebody came and said, I don't believe in masks, I don't want to wear it, we would say that's fine, but you're not going to be in the operating room. I think it's perfectly reasonable to say the same thing to healthcare providers, to say, it's not a right to be a healthcare provider. It's a privilege. You're doing it. It's your profession. But that part of that profession is to provide safe care.
All right, so we may have some disagreement on the panel about that. Before sussing out that disagreement, I want to say, again, we're going to open to audience questions, and I see some folks sitting nearish the mics, but I can't tell if it's because you have a question or not. You certainly do. So I'm going to go to this microphone first.
Hello. I know it's been touched upon, but I just want to get the final stance on the transparency of these choices that the health professionals have. I understand if you believe they do have a choice, but also as a patient, especially like an immunocompromised patient, what's their right to know the choice that they have made?
Great. So I might ask Scott and Janet particularly to chime in on that, and then the other two panelists as you see fit.
I think that patients do have a right to demand that the institution provides them in a safe environment. When they go into care, under their care, they have the right to demand that that's being done in the safest way. I think if you're a patient in the hospital and you see a physician walk into the room and he or she doesn't wash his hands or clean his hands beforehand, you have every right to say, turn around, wash your hands before you touch me. You do not have to put yourself at risk from the healthcare system. And vaccination is part of that. And so therefore, I think the public does have a right to demand that. Many of the policies that are being put into place are policies of mandatory masking during influenza season, in that you then, if you don't wear a mask, if you don't want to wear a mask, you can get immunized and you don't have to wear a mask. That allows the healthcare provider to have a choice. If they don't want to receive the vaccine, they are at least protecting against transmission of infections. But in some way, the patient does have a right to know that they are protected, I think.
Okay, and Janet, on that question about transparency about the healthcare worker's choice.
Wow, one of the things, though, is to demand that the institution provide safe care. Wow. Safe staffing might help. Anyway. So, do the patients have the right to know? I think that when a patient is admitted to hospital and there's a history taken on the patient, and they are compromised, or if a patient is like some of our neonates, absolutely. If you want to work in these places with these types of patients, then you either have to have a flu shot or you have to wear a mask. And then the nurse or the healthcare provider gets to make that decision. I don't think it should be a blanket. Every person working in the facility has to have a flu vaccine. I believe in certain situations, no question about it. But there are lots of clinics, lots of places. Does every single person working in the facility have to have a flu vaccine? that's where the debate is. I believe that healthcare providers, the physicians and the nurses that I'm talking about, in particular units, will either wear a mask or they'll get a flu vaccine, and they'll do that of their own accord. I know that the majority of our long-term care nurses get immunized. They do. And I'm sure it's because of the population that they're with. They know they're with a vulnerable society. They know that they're with the older clients, and they get it. They volunteer to get it. There's something about the whole coercion as opposed to persuasion that we all know gets people's back up. It just does. And I think we have to do a lot more education on the whole role of the flu vaccine. But we still have to respect someone's right to say, I don't want to get the flu vaccine. I'll wear a mask instead.
Okay, and Elaine on that point.
So I heard the question through my lens as a legal question, and I'm going to answer it in that way. When there have been challenges in Canada to the requirements of healthcare workers to either have the flu vaccine or some other method would be used to prevent them, as could be done from interacting with patients, with one exception, that requirement has been upheld by arbitrators as an appropriate requirement for the workplace. And this was most recently tested in British Columbia when they brought in a province-wide policy for institutions where the healthcare worker, was either to have a flu vaccine or to wear a mask during flu season. And the arbitration that challenged that, the arbitrator said that it was appropriate so long as it met a series of tests, i.e. employees were advised beforehand, there weren't less intrusive measures that were available, etc. And so this policy was upheld as it has been in most places in Canada.
Okay, and oh, sorry, I don't want to cut you off.
As being a right of an institution to institute such a policy. And implicitly then, this goes to the question that was asked, do I as a healthcare provider have a right to be protected from it? If an institution can bring in a policy, then that's saying the person has the right to be protected.
Okay. And finally, Robert, on this question.
I don't think I have much more to add. So.
Fair enough. So I'm going to go to the questioner who's been patiently waiting over here. I think is... Okay, great.
Hello. So my question, I guess, is focused at Janet, and you'll have to forgive my ignorance. I'm from the States originally, so I don't have a good understanding of how unions work in general. But for your union, I'm just curious as to how membership works. So you represent nurses in Nova Scotia. So do you represent specific hospitals, and then within those hospitals is being a member of that union contingent on your ability to work in that hospital?
That's probably a hotter question right now than you may realize.
Yeah.
Do you want to go there?
Do you really want to go there today?
Yeah.
Have you heard about Bill 1?
I guess I just wanted a yes or no.
Janet, if there's a concise answer to that question, do you want?
Depending on what your role is in the facility.
Okay, so if you're a nurse in a facility, do you have to be a part?
If you're union, there's depends on what your role is as a nurse. If you're a staff nurse, yes.
Okay. Okay, so, and this might sound like ad hominem, and I don't want to sound like I'm accusing or anything, but do you feel like that there's an inconsistency between the fact that your union stands on the position that you don't want your nurses to be forced to take a vaccine as part of their job, which I guess is a right of theirs, but at the same time your union survives on the fact that you have to be a part of that union to work in that hospital?
Well, I guess you're Canadian, you pay taxes. I mean, you live in HRM, you pay HRM taxes. I mean, life is, our whole issue is this is not a mask. This is a needle. This is it's intrusive. Nurses believe They have the right to make the decision for themselves, just like everyone in this audience does. Every flu season, you get to decide whether you're going to get your flu shot or not. You get to make that decision. And we're saying that the nurses are saying, and it's not me that's saying it, it's our nurses, are saying we want to be able to make that decision for ourselves as well. And if we can't, if we understand what that might mean, that might mean that if I'm working in an ICU, I'll either get my flu vaccine or I'll wear a mask. And let's be really clear. Nurses are not saying they don't believe in the flu vaccine. That's not what they're saying. That's clearly not what they're saying. And that's not what this nurses union is saying. We spend all kinds of money encouraging healthcare workers to get the flu vaccine. But we do believe that some nurses have the right to say, I'd rather wear a mask than to get a needle. Just like everyone in this room has that right today. Now, if you're going to make it mandatory for every Nova Scotian, that's a different conversation. Completely different conversation.
Okay, there's a question here at this mic. Oh, okay.
My question is
sorry, are these mics portable? Can we bring a mic over?
Yeah,
okay.
she's got it.
Thank you very much.
My question is looking at it on a financial end, and that is, if your nurses want to wear a face mask, do us as taxpayers pay for that, or do you provide them for your union? On the other hand, if you don't want your child vaccinated and they go to homeschooling, are they paying for the homeschooling, or is the general public paying for the homeschooling? Because everything seems to beat around the dollar, and all we're hearing from our politicians is we don't have dollars. And the other question there is, our scientists are being told to shut their mouths by our federal politicians. So unless they get an okay from our federal politicians, so are we really getting all the facts, or are some of these being withheld because of our federal conservatives?
Okay, thank you. So there are a number of comments there. Anyone in the panel who wants to pick up on any of those comments and questions?
I think there's a good point about there are financial benefits of influenza vaccination of healthcare workers. There are data that shows that some of the benefits in institutions that have implemented mandatory influenza vaccination, that there are less sick days, therefore there's less staffing problems, and so in general it does benefit the institution and the healthcare system as well. So there are financial benefits to immunization policies like this. I think I'll avoid commenting on the political part of it, but I definitely agree that the muzzling of federal scientists is not a good thing. However, the influenza, because most of vaccine research is done outside of government, at least we know the data is being made available there.
Any other comments there? Okay. So there's another questioner. So I just want to let people know, because we're getting close to the end time, and one of the great advantages of being in this room is how terrific the facilities are. One of the disadvantages is that there's a clear close time for the facility. So we do have to make sure that the event is over at 8:30. So I just want to make sure people are aware that that is coming up. So if you have another question, please get in line now. I'll turn to this. Well, sorry. I'll pick up with this mic again, and then if we get time, I'll also turn to you.
My 17-year-old daughter attends St. FX, and there was a meningitis, a couple of them. And my question is to Ms. Gibson. Is there any kind of legal requirements for educational institutes to provide timely information when things like this happen?
Oh, that's a big question. So the obligations of an educational institution that come to mind at first would be moral and ethical and not legal per se. Certainly, if you were talking about a minor, there would be an obligation to get information to the parents or guardians of the person. Outside of that, the obligations are more, I thought you were going to ask whether there's an obligation by the province to be providing vaccinations.
That's part of my second question.
Oh, okay.
Which I'm sure we won't have time for. So,
I'll just say that the obligations of an educational institution are broad, but they operate more from the perspective of need to educate the public and to provide a safe environment for the students under its auspices. And so in that way, there's an obligation.
And the other part of it is just we got two prescriptions for the different types of meningitis, but they're cost prohibitive for most people. And I guess to Dr. Halperin, you could comment on that?
Right. And I think Dr. Strang may want to comment as well, but we'll let Scott go first.
Why don't you talk about
So I'm gonna parse out your questions really quickly because I was directly involved and so number one on the communication, I was directly involved in both cases at St. X. And there was no need, there's no benefit to widely communicating to the broader St. X community because we knew exactly who was at higher risk, and we'd already talked to all those people. So, and St. X was following my advice and recommendations. Your second one around the obligation of the province to provide, we did do that when we reached a situation at a different university, Acadia, where we had an outbreak and vaccine was required. We did it right away. We didn't meet the criteria for providing vaccine at St. X, different circumstances, but when we did, we moved in very quickly. The third piece, I absolutely agree. There is an equity gradient around when we said to people, even if you don't need the vaccine, but if you're in a circumstances where you're concerned about it, fully acknowledge that not everybody can afford that, and I don't have a solution to that, but I'd be happy to chat with you after in more detail on specific circumstances.
Okay, and Scott? Okay.
Rob answered the cost.
So we redirected your question, but I hope that was the right answer. And you've been waiting very patiently, so you have a question.
My question is for Ms. Hazelton. I just wanted, the discussion has been centered around influenza vaccines for nurses, and I just wanted to see if there's been any discussion about making sure that healthcare workers and nurses are vaccinated in other areas that might not be prevented by a face mask, things like childhood vaccines, and I know they're not well documented, but I know I work in the hospital and had to show proof of immunization by blood tests before working there, and what their opinions on that would be, and if they were found to be not immune, if that would be a cause for mandatory immunization and something that might not be prevented by a face mask.
The only one I know of is hepatitis B, right? All the childhood vaccinations, I don't recall. I mean, I'm a nurse. I don't recall being asked. We used to be asked about TB, and we used to have to get chest X-rays. But I don't recall being asked in a long time. Yeah. Maybe the newer employees up there can ask.
It depends on the institution. Yeah. So, for example, at the Children's Hospital, the IWK, it's required as a condition of employment that you're immunized or show protection against chickenpox, against measles, against rubella, as well as hepatitis B.
The commenter makes the point that you also have to be immunized to make it into nursing school.
Yeah.
So again, because those vaccines, once you're immunized, it's long-term protection. By the time you get into the situation of working, you are protected, and you don't. The difference with influenza vaccine is because it's required each year, and that's why that's become a bigger controversy than those other vaccines, which are also required to be immunized for.
So, I mean, Janet, not to put a sharp point on it, but is there a basis for, would you object to a similar requirement for nurses to demonstrate child, or to take up the vaccine as an adult if it were dealing with MMR vaccines?
Yeah, I agree that the issue is more around the annual flu vaccine as opposed to the other vaccines. You know, the other vaccines are a condition of employment. I think the annual piece of it is what's creating this controversy.
Okay. Any other panelists on that?
And it's a little different, too, when you're coming as a condition of employment when I'm going to get my job, and these are the things that I have to do to get my job. This is something that's just been introduced, and it's now becoming a bigger issue because it's mandatory to keep my job. So I think, you know, the whole, that's the issue more, a finer point on the issue. I think it's the annual flu shot that's creating this stir as opposed to the general vaccinations.
And just to drive home that legal point, there is seen to be a difference in law between seeking employment in a certain sector and what you need to provide to get a job with them, in contrast to an ongoing term of employment. In other words, you're not entitled to apply for a certain job and meet all the, you know, the employer is perfectly entitled to set up a great number of qualifications for that job. Whereas once you're already in employment, you're into a whole different ball of wax in terms of what the employer can require of the person for an ongoing condition of employment.
Okay, and that will have to be our last point for the evening in order to meet our time constraints. So I know that there are some unanswered questions that were waiting in the live stream queue, and I apologize to them. And to those of you who are watching online and texting me personally with your questions, you don't get to jump the queue just because you happen to have my number, so I'm sorry for that. But to wrap up, I'd like to invite up Dr. Judy Kazmersky. So Judy is a CCEPA board member, and since 1971, she's been in family practice in Windsor, Nova Scotia, serving as Chief of Obstetrics from 1980 to 1996 and currently practicing at the Hants Shore Community Health Clinic. She's the past Vice President of Medicine for Capital District Health Authority in Halifax and the former President of the Canadian Medical Association, and becoming the CMA representative to the World Medical Association and an executive member of the Medical Research Council of Canada. Welcome up, Judy.
Thank you very much. Let it never be said that CCEPA does not bring challenging issues to the public forum. I want to thank people for this evening, generally, and make a few comments first about what I heard. How many people saw the article in the Globe and Mail on March the 16th? This was an article, March the 16th, 2015. Thank you. This is comments from Rona Ambrose, the Federal Minister of Health. And she's basically talking about another dose of common sense, the dose being the dose of the vaccine for immunizations, making the points that vaccines are miracles of modern medicine. The language used by Dr. Halperin was serve a public good. She makes the point, vaccines save lives. We've heard that from all of our panelists. Millions of lives, not only here, but abroad. And now we're saying, how can we help other countries that need what we have? What she also says is the culture of fear that has been created by putting too much emphasis on the lack of appropriate scientific evidence. So this being the point made by our colleague, evidence versus anecdote. As you look at making decisions for yourself, for your own family, and for those around you, for your parents going into seniors' homes, look at the evidence. It's very easy to Google and get all sorts of anecdotal evidence, but make the decisions that affect you on the basis of solid evidence. One of the challenges created this evening, and we've asked it over and over and over, is what is in the best interests of our children and our society? We've pointed out several areas where there can be improvement in what we're currently doing in the area of immunizations. When I first started practice in this province, there was no way of doing registration. And then Dr. Nuala Kenny, a pediatrician, started a method of producing an accountability document, and we'd fill it out and then send part to public health, give part to the patient, and we would keep part of that. And now we've moved to electronic records, and so again, there's an increased opportunity. But until we have the ability to look at ourselves, to look at who is being immunized, are there pockets of populations that are not being immunized? We can't look at the bigger picture and understand the full impact. It doesn't take a great deal to just ask you for a moment to look around you and look at the people who are here, the people who are here with families, but also to look at what we have in this Halifax Central Library. I'm going to call it a model architectural learning center. I was here earlier with CCEPA for the presentation that was done around the time that we had issues in the dental school and the concept of misogyny. The place was absolutely packed. There's a wonderful audience here this evening as well, and I thank you very, very much for coming. But the debate and the gathering of information is equally intense in all of those venues. The people from CCEPA, Canadian Centre for Ethics in Public Affairs, welcomed the partnership with the Dalhousie Law Institute this evening and the sponsorship of the Nova Scotia Nurses Union. And especially to you, the audience, for coming out this evening, and I hope going home and having this debate and this discussion with your friends. Let's call it an informed conversation so that we start to perpetuate the building of a society that really cares about the decisions it's making and its impact on them personally, their families, and the community in which they live. The Atlantic School of Theology and St. Mary's University were co-founders of CCEPA and have tasked it to talk about and to create forums where we can talk about, big quotation marks, how we live matters. The issues we've talked about this evening matter a great deal. And I hope that that discussion only will continue when you get out after this evening. I invite you to come to other events put on by CCEPA. There is one coming up, Ethics in the Evening, with Dr. David Dean on April the 20th. There is another one, the Marshall Lecture in Public Philosophy. This has been on your seat, and you can take a look at it. The Ethics of Climate Change with Dr. Nancy Tuani. Both of those are issues that serve to possibly affect all of us. My thanks to our very strong moderator, Kevin Kindred, and to the panelists themselves, Dr. Robert Strang, Chief Public Health Officer, Dr. Scott Halperin, Director of the Canadian Centre for Vaccinology, Janet Hazelton, President of the Nova Scotia Nurses Union, Elaine Gibson, Associate Professor of Law, Schulich School of Law. Thank you very much to all of you. I welcome you to go to the CCEPA website and the Facebook page for not only the events coming up, but to engage in some of the discussions that are currently going on and to become a part of the CCEPA community. Thank you very much.